all the panelists what they think and how we can understand it further better. But it will be a story kind of thing when it will be nice to get discussion.
Yes, exactly. I see Dr. Kozin here. Hi, Scott. Hi, Stephanie. Hi, Michael. Hey, Mike.
Hey, Stephanie. Hey, Mike.
Hey.
Scott, you're hiding.
I'm trying to get my video to work.
Okay. Well, we hear your voice.
I think it feels still dark.
Yeah, we hear your very nice voice, but unfortunately, can't see you. But I'm sure that'll be fine.
Just give me a second. I'm still working on it.
Okay. Yep. And then we're just waiting for Dan. I'll send him a message again just to see if he can join. And then is Eugene here? And Praveen. Hey, yep. We see you. Thank you, Dr. Kozin.
Thank you, Brother Kozin.
Oh, Dr. Joubert's here. Is that Joubert?
Yeah.
Okay, I think I see something there.
Yeah, he's there.
So, okay, awesome. So we still have Praveen and Dan, but I think we're kind of, we're about 1 minute past 9. Tommy, do you think we should start?
Maybe we have a test with Dr. Joubert because.
Okay, and then let me just check if he's. Dr. Joubert, are you there?
Yes.
Oh, hi. Good to hear from you.
But we haven't seen you. We hear you very well. Do you mind to open the camera for us? This is Tommy and Johnny from Chang'an. Yeah.
Yep. There's Eugene.
Hi, Eugene. Morning.
Okay. Well, no pressure for Dr. Joubert, but if you can comment or anything, yeah. But I think we're. Oh, Dan's here. That's awesome.
Hi, Dan. Morning.
Oh, hey, Dan. Good to see you. Wow, this is fantastic.
Hi, Dan.
Hey, Dr. Joubert. Hey, Dan. Hey.
Hello.
Hi,
Oh, wow.
Joubert.
It's a Christmas party. Awesome.
Hi, Dr. Joubert.
It's a party.
It's a party. I think we just have Praveen's kind of missing from here, but I'll send him a message. But I think we can get started. Tommy, are we good?
Yeah. Sure. Thank you, Johnny, for arranging everything, and thank you, Maulin, for sharing this very challenging talk and very valuable. And thank you all the teachers with us, and especially the first time with Dr. Joubert. Thank you so much, everyone. And Johnny, we can start. Thank you.
Okay. Well, before we start, first of all, I want to thank all the panelists for joining. For those of us that probably first time joined, like Dr. Joubert, this is meant to be kind of a main feature, a main presenter who's going to present for probably 35 to 40 minutes. But Maulin's kind of separated into 3 sections where we're going to have kind of, after his first section, he's going to stop and then probably ask questions and ask if anyone has any comments. Kind of a bit interactive. And I probably won't do the usual thing of asking all the panelists to comment. I probably will just kind of, you can use your hand, or you can use your, hey, Praveen, good to see you. Thanks for joining. You look like you're operating, but thank you so much. You can use your hand or your fake hand, whatever works. You can use a heart, whatever, but the fake hand is always nice and useful. And then I'll try to get you to comment. And then as soon as we kind of move on, and so we finish a set of questions or comments, and we move on to the next section. This whole session we'll try to target for within 2 hours, so that we know it's a Saturday, so people will be kind of doing a lot of their own things. But it's a very interesting topic. So this is the IMC, or International Microsurgery Club, in collaboration with the American Society of Peripheral Nerve. We call them the Nerve Without Borders, kind of that section. It's been very exciting. We've done, I think, over 40 or 50 of these again. And, like Dr. Kozin, Dan, Praveen, you guys have all been here since the start. So really glad. Today, we're going to have Dr. Maulin Shah from India to talk about this topic, elbow block test, a clinical sign of dynamic anterior shoulder instability in residual brachial plexus birth injuries. We're very, very honored to have him here, and then also very honored to have our panelists. Started off with Dr. Scott Kozin from US, Dr. Zlotolow from US, Dr. Praveen Bhardwaj from India, Dr. Stephanie Russo from US, Dr. Eugene Park from US, Dr. Steve Koehler from US, and Dr. Michael Aversano from US. I probably should have went different state, but I don't want to get confused or anything. So this is a very much a US dominant. And then we're also very happy to have the prestigious Dr. Ellen Jaber here, to be here. But Dr. Jaber, no pressure. It's just you can comment or anything you want and just let me know. I'm just briefly going to go through Dr. Maulin Shah's, his background. He completed his pediatric orthopedic training fellowship at Children's Orthopedic Center in Mumbai in 2000, and then later on in 2005, and followed by a visiting associate professor at University of Iowa Children's Hospital in 2006. He then did a very prestigious fellowship at Sick Kids in 2008 to 2009, and that was when he really got a lot of extensive exposure to pediatric orthopedic surgeries and also brachial plexus care, namely in the neonatal population. He has really dedicated his career into brachial plexus birth palsy and has been instrumental to push for studies such as this, the elbow block test, and then also to do the minimal invasive subscapularis, minimal scapularis release technique. He's published over 40 publications, has really won multiple awards in India. We met in BrachialCon, I think I forgot when that was, but it was it was in March or something like that. I think so. And, and that was a very nice opportunity to really get to listen Maulin's kind of philosophy approach. Instead of really just describing this as a phenomenon, he really went ahead and described the mechanism behind it. So I think today we're all eager to hear from this. And without further ado, let's get started. Thank you.
So should I share my screen, Johnny?
Yes, you may. Yes, please.
So can you watch my screen well?
Yes.
Yeah. Perfect. Thank you.
You may start. Thank you.
So thank you very much, Tommy and Johnny, for this opportunity and the platform. And I'm grateful to the panelists who are real stalwarts of the field, and we have read their textbooks, and it had kindled our interest into the subject. And I'm very happy to share our research work through this platform. So my topic is elbow block test, a clinical sign of dynamic anterior glenohumeral instability. And let's go this way. So those who not know me, I belong to Ahmedabad. It's a capital of the most western province of India, that is Gujarat. Very well known by its prime minister's home ground, Dr. Narendra Modi, and it's UNESCO's heritage city of India, the first heritage city of India, a bit north to Mumbai, north southwest to Delhi, but it's one of the metros of India. And this research work was done with me, Dr. Nishal Nayak, who's a plastic surgeon with key interest in plexus reconstruction, and Dr. Tejas Patel, who is a pediatric rehab specialist. And for now, last 16 years, we have been running this comprehensive pediatric brachial plexus clinic in Ahmedabad with 1,200 patients enrolled so far, more than 1,200. Well, India is a very big country, and in first 10 years of our practice, we found that about 60% of patients were referred to us after the first year of life. That was a very sad state of affair. And last 5 years, this rate has gone down to 30%. So the referral systems and awareness has increased, but still we see a lot of neglected cases who did not receive the timely nerve surgery. And hence we come across a lot of residual palsy patients. And that gave us an opportunity to study this subject. Now, for the ease of discussion and the flow of the talk, I have divided my talk into 3 parts. The first is the clinical characteristics of patients with elbow block test. The second one will be the biomechanical studies to ascertain the possible etiology of elbow block test. And the third will be surgical implications of elbow block test, which would interest to most of us. And I think I can stop at the end of every section and we can discuss and we can get suggestion from the panelists. We all know the Naraka's classification with a beautiful monogram published in 1987. And the C56 carries a huge proportion of the total population of our 55 to 60%. And as we go down, the percentage of affection goes down. And so we are all well versed with the deformities and limitations in the C56 or upper plexus palsy. And the deformities in Erb's palsy is a muscle imbalance, which might be because of lack of innervation or the co-contractions or the failure of elongation of the innervated muscle as described by Roger. But we see a typical clinical signs like limited passive external rotation, or when this degree goes fairly low, it can be termed as the internal rotation contracture. So these are very common sign we see in upper plexus palsy. We also see these patients have persistent internal rotation posture of arm, and when we ask them to reach to mouth, they tend to lift the arm, and we term it as a typical lateral trumpeting. And we also see that these patients have concomitant limitation of shoulder abduction and external rotation. And these clinical signs are very familiar to us. But conventional treatment, and therefore, is to release the subscapularis and the soft tissue and transfer the tendons to balance the shoulder joint. However, anecdotally, we saw in our clinical practice that some of these patients have very good degrees of active and passive external rotation, both in arm adduction as well as abduction. But when we ask them to abduct the limb, their abduction is limited to less than 90 degrees. Their elbows get flexed. Now the question is why there is non-concomitant or disproportionate limitation of the shoulder abduction and external rotation. Is it because of the limited innervation of abductors as described by Dr. Al-Katan? Or is it a co-contraction between the shoulder abductors and adductors as described by Dr. Chuang? And the other thing what we observed, that the moment we put an elbow extension splint in these patients, abduction improves spontaneously. So we hypothesized that these two forementioned etiologies are not possible cause of this phenomenon. And hence, not moving. Yeah. So we hypothesized that blocking the elbow flexion induces some biomechanical changes, and it improves the shoulder abduction spontaneously. And we termed this test as an elbow block test. And the aim of this study was to apply the elbow block test consecutively to the patients with residual brachial plexus palsy to identify in which patients this abduction improves, and what are the clinical characteristics of these patients, and finally to identify what is the possible etiology of this improvement. And to study this, we applied this test in 156 consecutive children with residual palsy between 2019 and 24. I saw this phenomenon for the first time in 2012, and since then this question was arising in our mind, but we systemically studied this population after 2019, wherein we first measured the abduction of the limb by measuring the angle between the torso and the medial border of the arm. And then we checked the amount of elevation after application of the elbow extension splint, which typically extends from the proximal brachium to the distal forearm with an overlapping strap to prevent any undue elbow flexion. And then we measured the amount of abduction, and we measured the difference between these two, pre and post test. We included patients who were chronologic more than 2 years so that they can follow the test. And we excluded previous shoulder rebalancing surgery patients to remove the effect of iatrogenic weakness of the patients, of the muscles across the shoulder. And we also excluded the patients who have abduction less than 30 degrees because they were having denervated muscles to produce any beginning of motion. We found a typical correlation in our clinical practice between the degrees of passive external rotation at shoulder in arm adduction and improvement in abduction after application of elbow extension splint. And hence we try to plot them on a scattered diagram. And as you can see here, the scattered plot, where the x-axis represents the passive external rotation in degrees, and the y-axis presents the degrees in elevation after application of the splint. The blue triangles mentions the elevation without the splint, while the red dots presents elevation with the splint. When we follow this scattered plot carefully, we found a red dashed line which suggests that higher the passive external rotation with the splint, there was higher degrees of elevation. And the blue dashed line shows the higher the passive external rotation without a splint, there was lesser the elevation. So we applied an exponential regression model based on these findings. And we found that the slope at the critical threshold of 60 degrees of passive external rotation was only 0.36. But the more passive external rotation happens, there was a steep rise in the curvature. The slope raised to 0.57. And the critical threshold we found at the y-axis was about 29 degrees. And thus, this exponential regression model suggests that after 29 degrees of elevation, there is a higher rate of improvement shifts. And based on these findings with our biostatistician, we defined positive and negative elbow block test. We defined positive elbow block test as an improvement in abduction of more than 30 degrees after application of splint. And if this improvement is less than 30 degrees, we would consider it as a negative test. Now, after defining this test, we looked at the clinical parameters, that how they are different. And we used different outcome measures like active and passive shoulder range of motion, 6-point modified Mallet score, degrees of elbow, forearm, and wrist deformities, and strength of upper extremity muscles through MRC grading. And we tested it all these 156 patients. And to study the biomechanics of this, we did multi-channel surface EMG, dynamic ultrasound, and dynamic CT scan studies, which we'll talk in the next session. And of course, we measured the surgical procedures performed in these patients, and we noted, and that we'll discuss in the third section of my talk. 69 patients were positive for elbow block test, while 87 patients were tested negative for the elbow block test. Average age of patients were 5.4 years. There were 6 parameters which we found significantly different between positive and negative tests, and I'll discuss them one by one. The first one was the passive external rotation. We found that the patients with positive tests has average passive external rotation of 70.3 degrees, while it was only 22.2 degrees in negative tests, with a median of 70 in positive and only 10 degrees in negative tests. And if we consider that passive external rotation less than 40 degrees, the beginning or establishing of internal rotation contracture, only 7.5% patients had passive external rotation of less than 40 with the positive test, while 84% of patients with the negative test, meaning that the negative test patients have more restriction of external rotation than the positive test. The second parameter which we found different was a passive internal rotation, which we measured with the arm abducted to 90 degrees and tried to bring the forearm to the couch. On your left side, you can see the non-affected side where we could easily bring the arm down, forearm down. But on the left side, we could not bring it down. And the angle which it makes with the horizontal were termed as degrees of passive internal rotation deficit. In sports medicine, This passive internal deficit has been corroborated with either a posterior capsular contracture or the contracture of the external rotators at shoulder. In older children, this can also be measured with the child standing upright, and the degrees which is lacking, that has to be mentioned as a passive internal rotation deficit. We found that the positive test patient in 64.7% patient had demonstrated passive internal rotation deficit, while it was only present in 17.4% patients in the negative test. When we looked at the 6-point modified Mallet score, while global abduction was less in the positive test and global external rotation was more, one important finding which Dr. Kozin and their colleagues have devised as a hand-to-belly function, we found that the hand-to-belly was limited to 2.9 in the patients with positive test, while it was 4 in the negative test, meaning that their ability to internally rotate the shoulder was less in this subgroup of patients. When we also saw that when we turn the babies in the standing posture, they will show their limitation to reach the midline with the palm flat. And so we took, when the hand to belly is less than or equal to 3, meaning that if a child requires significant wrist flexion in order to reach the belly, that was seen in about 70.5% patients with positive test, while it was seen only in 28.6% patients with a negative test. Some of the patients had significant limitation that they could not reach to the belly at all. Remember that these are not operated patients, so these are not iatrogenic external rotation contracture, but they were the study group patients. And when we looked at the triceps strength, we found that 48.5% patients with positive test demonstrated some form of triceps weakness with MMT grade less than 3 MRC grade. And while there was no significant difference in the elbow flexion deformity in both the groups, the magnitude of deformity was found fairly high in the positive test compared to the negative test. And finally, the sixth parameter, which we found that while we see a typical lateral trumpeting in Erb's palsy patients, we found that most of these patients with positive tests required forward flexion at shoulder in order to reach to mouth, and we termed this as a forward trumpeting. So a forward trumpeting phenomenon was seen mainly in this patient with positive tests. That was seen in about 80.8%, while it was seen only in 23.2% patients with the negative test. So if I summarize these clinical findings, what we found the difference in both the groups with the positive elbow block test patients has a more degrees of passive external rotation compared to the negative test. Passive internal rotation was reduced in positive test patients. Triceps strength was suboptimal in positive elbow block test in more number of patients. Hand to belly was compromised. The forward trumpeting was seen in positive test patients, while lateral trumpeting was seen in majority of patients negative test. And elbow flexion deformity of higher magnitude were reported with the positive elbow block test. So if you come across a patient like this, look at this boy whose right side is affected and right limb looks a bit in external rotation. And the moment you ask them to elevate, the elbow gets flexed, elevation gets limited. The moment you put an elbow extension splint, the abduction spontaneously improves more than 30 degrees. These children have active external rotation with arm abducted and adducted, but they have difficulty in reaching midline. As you can see, this boy having hand to belly grade 3. And you see they can reach behind the occiput. Some of these patients lack terminal external rotation strength, but most of them, they can reach behind the occiput. And when we ask them to take hand to mouth, they forward flex their shoulder. In this patient, the patient also had supination deformity. I could not pronate it completely. And there's about 25 degrees of elbow flexion deformity, as you can see here. So these were the clinical synopsis I could observe in this group of patients. And Johnny, I think we are open to discussion for this clinical part, I'll be happy to answer if there is any question.
All right. If all the panelists could have the cameras on and stuff. Does anyone have any comments or any questions? And I think Scott, you had a comment from in the chat.
Yep. Can you hear me?
Yes. We can hear you.
Yeah. So, it's super interesting stuff, actually. So first and foremost, kudos. Second is, like most things, our therapists find out and figure out things before we do. Right. So the placing the brace across the elbow, our therapists figured out a long time ago into this particular subset of people. So I guess, it seems to me, just globally, that this elbow block test is applicable to a particular subset of BP kids that have probably some C7 involvement, so the intermediate group. Is that true or not true?
Yeah, that is absolutely true. And by the end of next session, you will understand the correlation. But I absolutely agree with you.
Stephen, you had your hand up, and then Stephanie, Dan. Stephen?
Yeah, I think as Scott said, this is interesting stuff, and I've seen the same thing. My therapists do the same thing. They put it on, and then you can lift these kids' hands up. It's interesting. I appreciate that you excluded the iatrogenic population. Bertelli just published his series with Francisco on the children that had developed this from surgical releases or tendon transfers where they lost their midline function and internal rotation and developed that secondary GERD. They saw that in all their patients that had C5 to C8 root injuries. As Scott and Dan have already published before, if you don't have a good C7 and you do something, you can lose your midline function. What's interesting, though, is they were all T1 hand patients that they reported this in. And when you look at Naurakis's original publication, it, as Dan has talked about too, it's a spectrum of injury. It's not actually those four groups that we are commonly citing. And in the group 3 patients, they have sometimes Sunderland 3 and 4 degree injuries to C7, but C8 and T1 are less affected. But in group 4, there's kind of the group that have a significant injury also, like a Sunderland 5 to C7, and then they have varying degrees of injury to C8. So one of my questions for you is how much of this is a GERD type issue, and how much of this is a triceps insufficiency or only partial function, perhaps just by the medial head and your lateral long head's not functioning?
Yeah, so those questions were definitely coming to our minds, and maybe by the next biomechanical studies we can answer. But as you rightly said, that the triceps insufficiency was found in fairly large number of patients. Now we have published our results of Botox in internal rotation contracture, and we found that those patients who had C7 element like wrist extension weakness, subtle weakness, or a triceps weakness, those patients develop inability to reach midline with palm. So when there is C7 element involved, I feel that lower subscapularis is also supplied by C7. And so they are tight but weak muscle. And it's not only for the surgery or release of subscapularis that insertion, but even Botox injections can lead to weakness of this. So we have to be very careful. And I think I'll come to that part in the, so you are rightly commenting about triceps, and triceps have a significant role. And I'll explain how it is important.
All right, thank you. Stephanie?
Thank you for this great talk. I think our therapists have also been seeing similar things, and it's nice to have kind of larger cohorts and some more discrete analysis of the phenomenon. I had two questions. One is, have you looked at varying degrees of elbow flexion to kind of immobilize the elbow in, to see if that makes a difference in the increased abduction that you see? And have you, maybe this may be what's coming next in the talk, but have you done any intervention based off of this idea to try to create some long-term change?
Yeah, so that I'm going to discuss, and the elbow extension augmentation is extremely important. And what I've learned over a period of time is, as these children grow beyond 1 year, you cannot identify whether they were Naraka's 1, 2, 3, or 4, because if it's kind of neurotomasis kind of injury, they have recovered to some extent, right? So to apply this classification in grown-up children, that makes it very difficult. So we have to identify other ways to classify them and their limitation. And elbow block test is one of them, because it's not a clear-cut distinction between Naraka's 2, 3, and 4 once they grow up. It's very important to understand the indications of nerve surgery, but once they grow up without nerve surgery, they behave absolutely differently. And as you pointed, I will discuss how elbow extension augmentation improves the outcome in these patients. Yeah. So yeah.
No, we have a lot of questions, so let's get this going. Stephanie, did you have a second question? Or sorry, I missed it. Okay.
Could I answer you, Stephanie?
Yeah, the other question I just had was, have you tried different amounts of elbow extension?
Okay.
So no, I have not tried that. We have placed elbow extension splint in possible elbow extension, meaning that if a child is having 20-degree elbow flexion deformity, so we have applied the splint into that angle, and we have not seen if a child is having certain degrees of elbow flexion deformity, whether there is difference in the amount of elevation or abduction after applying this elbow extension test. We have not done that, but we will do that. That's an interesting point.
Yeah, and just ask because there's some basic science study on musculoskeletal modeling that suggests that 30 degrees of...
But what I know is once we correct them, that leads to improved elevation. So surgeries done around elbow affects abduction at shoulder also. So then how it affects, I'll let you know in a moment.
Okay. Thank you, Stephanie. Dan, I think you've been waiting there for a while. Dan? All right.
You hear me?
You need to unmute. Okay, good.
I did.
I see you unmuted.
All right. Maulin, really interesting. I think there's a, now hearing your sort of full presentation, because I've always wondered what this all about, because it doesn't make any sense to me, but I think it's starting to make sense to me. I think I go back to my, hang on one second. Sorry, my wife was vacuuming. Okay. So, right. I think that when I look at our spinal cord injury population, our spinal cord injury population has normal shoulder, right? So if they have triceps weakness, they will do the same thing. So they will elevate maybe 90 degrees, and they will go as far as they can go before their elbow falls on their head.
Yes.
Right? And so I think that this concept is something that Scott actually talks about and that taught me is this idea that children will not, or even adults, will not abduct their shoulder if they have no control of their triceps, right? So what we're talking, and I think that, this is something that we don't think about so much in plexus patients, but I think you're absolutely right. Yeah. It's a very similar sort of phenomenon.
And the similar thing, it is my sports surgery friends, they say they see similar phenomenon when the traumatic subscapularis tear. So those patients behave the same way. They have limited elevation, they limited abduction up to certain degrees. So, yeah. So this phenomenon is seen in...
Sorry,
Dan,
to cut you off. Go ahead.
Dan, keep going. Sorry.
Okay.
Yeah, Dan, finish your comment. Sorry.
Yeah. So I think that you're right about the subscap. Subscap, as Scott taught me, is 5, 6, 7 innervated. And so when you have a 5, 6, 7 injury, you're going to have subscap weakness and you're going to lose that internal rotation strength. And if you've had a lot of recovery, particularly if you have something like quite a bit of 5, 6 recovery, but no C7 recovery, you are going to have weaker internal rotation. That's for sure. And then I think I think the other thing that we need to bear in mind is something that Steve just said, is the Neuracus classification, I think, has been so confused over the decades. And I think we just have to be clear about what we're talking about. And I think Steve's right. The one thing, I think that there's been so many sort of permutations of the Neuracus classification, and we've talked about this extensively, but I think that when you look at we found in our research looking at how to quantify intraoperative versus preoperative guesses as to what our injury was, we are really bad at differentiating. We're really bad at differentiating C5-6 injuries from C5-6-7 and even C5-6-7-8 injuries. So as soon as you get into any kind of 7, it's hard to separate that from 8 as well, because there's a lot of triceps. You can get normal triceps with just C8 function.
Yeah.
Yes.
And so I think part of what you're seeing is, I think 5, 6, 7, 8 injuries more so than just 5, 6, 7 injuries. And because I think the injuries are always worse than we think they are, because the kids recover a fair amount. So those are my 3 or 4 cents on this.
So, I agree with you. And at the end of this talk, I will propose a kind of new classification we should apply to residual palsy patient. And I have failed to apply Neuracus classification in my patients. So it's just a thought I will share with the panel. So, Johnny, should I move ahead now?
No, if it's all right, I still, there's 2 hands that are still up, Praveen and Michael. So I'm glad that there's questions. So Dan, this is not the finish of the completion of the presentation. There's still a lot more. So Praveen and Michael, sorry you guys waiting, but Praveen?
Yeah.
Hi, good to see you, Praveen.
Hi. I think, it was nice to hear. Maulin and me have been discussing this for almost 10 years, I think so.
Yeah, that's right.
And we're doing the study parallel, he does, and in our institution we also do, and our observations were almost the same. I think one striking thing which was common in all the patients was the loss of internal rotation.
Yes.
So Dan mentioned about the triceps. Triceps, surprisingly, there is a section of patients who have good triceps function.
Yeah.
So I think one thing which is consistently associated is the lack of internal rotation. So maybe they are having that instability which has caused a fixed external rotation.
Yeah.
And Stephanie asked a very interesting thing, whether you splinted in different degrees of elbow flexion. Actually, I got this idea and we did that. So we splinted in full extension, 30 degrees, 45 degrees, and 60 degrees. So if you splint in 60 degrees, this phenomena does not happen. So if the elbow flexion deformity is more than 45 degrees, you will not observe this phenomena of increase in abduction. So then we were seeing the biomechanics studies. They say that the biceps stop behaving like an anterior stabilizer after 45 degrees.
So Praveen, let me top that. In biomechanical studies we have done.
So I think she got a very good point, and I think it is there in rotating in everyone's mind, and it is an interesting concept.
That's true.
So thanks for bringing it out.
Yeah.
I mean, that's a great feedback. Thank you.
Could you just repeat that, Praveen? What degree elbow do you not see this work again?
After 60, right? After 45 degrees, the effect reduces, 45. And after 60, no effect at all. So any child who has got a flexion deformity of 60 degrees, this effect was not seen.
Okay.
Yeah.
Thank you, Praveen. I would like Mike to make the final comment, and then we can move on. Mike? Thanks for waiting.
One of the other things to kind of look at and differentiate too is what percentage of this motion is coming from the scapulothoracic motion and what's coming from the glenohumeral joint. Because what you see and you might see is that the brace changes the lever arm and provides more scapulothoracic motion in a certain elevation point. And then you're just tipping the scale so that they then benefit from kind of this increased lever arm. And that goes along with kind of the triceps strength as well. So if you could lock your elbow in a certain position, then you could potentially elevate more because of that. So I'm really interested to see your biomechanical data to look at this, because I think you'll probably touch on it more, but I think that's something that we should also think about, because shoulder motion has two main components, and we kind of see both of those play into account in brachial plexus patients, especially with like the work that Steph's doing to see all that stuff too.
Yeah, so it's very important when we are examining this patient, the therapist, or we have to stabilize their shoulder. Otherwise, they can easily cheat, and you may assume that there will be more angle. And most importantly, their clothes should be off, because if they are wearing clothes, then you may be misguided by the amount of abduction, but it should be bare, and then you can measure the angle between the trunk and the arm. So I agree with you. Okay, so should I move ahead, Johnny?
Yeah, Maulin, why don't we, for the purposes of time, why don't we do the second and third section together so that we can save more time for the discussion? Because this is great. That's good. We're getting a good head start. So let's go.
But I'm sure there will be more questions than this after biomechanical studies. That's why, anyways, we'll take a call. So to look into this, it puzzled us that what is happening at the shoulder joint when we prevent elbow flexion to happen. And the first thing we try to do is a dynamic CT scan study. And as in our centers, we do not have an upright CT or MRI so far, but now in last month, there was one upright MRI has been installed, and so I would be studying this in the upright position as well. But what we found that we took 10 patients who were having positive elbow block test, and we did the dynamic CT scan study. We looked at their axial glenohumeral articulation at resting posture. And you can see in this image that all the positive block test patients have normal version of the glenoid. They were not retroverted. And the glenohumeral articulation was found well. There was no subluxation, meaning that there is no anterior subluxation at rest. Then we asked the patients to abduct the arm as much as they can on the affected side and do the same abduction on the opposite side. And we took patient for CT scan. And you look at this, the second image, the left side, on the right side is not affected. On right side at 70 degrees of abduction, the humeral head is still located. But on the left side, there is anterior subluxation of the humeral head, as you can appreciate here. So we found that there is dynamic anterior instability in these patients. And when we ask them to abduct the possible amount of abduction, there is subluxation of humeral head in front, which prevents further abduction. And then we applied the elbow extension splint and asked the patient to do the amount of abduction they can do. And the final image shows that once we apply the elbow extension splint, there is spontaneous recentering of the humerus over glenoid and the abduction improves. So this dynamic CT study showed constantly similar finding in all these patients, that they are showing some degree of anterior subluxation at the amount of possible abduction. And the moment we put an elbow extension splint, they can elevate and their humeral head gets centered. Now, we also wanted to study that this was an axial antero-posterior stability, but what is happening in the supero-inferior instability, and for that we performed a dynamic ultrasound. And what we found in these 10 patients, the distance between acromion and cartilaginous humeral head was 0.49 centimeters at resting. The child, when he asked to do possible abduction without the splint, this distance reduced to 0.37 centimeters. Ideally, we should see some degree of lower glide of humeral head so that the center of rotation remains a little centered. But here it was 0.37, it reduced. And the moment we applied an elbow extension splint, this distance increased to 0.99 centimeters and elevation improves. And this suggests that once we apply the elbow extension splint, there is some compression or lowering effect of that extension splint, which centralizes the humeral head against glenoid, and it doesn't allow to abut the humeral head with the acromion. So this is probably providing some supero-inferior stability, which we could confirm through the ultrasound study. Now we tried to, the normal SCOT is, normal is there will be some reduction, some increase in the distance with elevation. But here, on the contrary, we found some reduction. And when the abduction improves, the distance increases substantially, as you can see. When we looked at the normal counterpart or the opposite unaffected part, with the amount of possible abduction, this distance improved from 0.49 to say 0.64. And when the abduction was complete, the distance was further more. So probably in these patients, the supero-inferior stability is also missing, and this leads to reduced distance. Now we try to look at what muscles are involved, which leads to this phenomenon. And for this, we kind of collaborated with Indian Institute of Technology, Human Centered Robotics Lab, and they had this multi-channel surface EMG devices. And we took these 10 patients to the IIT Gandhinagar in Ahmedabad. And what we found that in healthy side, the biceps and deltoid, they start showing contractions after 30 degrees of abduction. And this is a fairly lower MAV when they start abduction. But when we compare this healthy side with the affected side, you can see the biceps and deltoid start showing more MAV, and they contract absolutely together in all the range of abduction, meaning that these two muscles are co-contracting. The elbow flexors and deltoid are co-contracting in this group of muscles. We saw that there was no co-contraction between pectoralis major and deltoid, but there was significant co-contractions between elbow flexors and deltoid. Now, when we looked at what happens to this when we applied an elbow extension splint, even though the elbow flexion was blocked by the splint, there was higher degrees of biceps contraction. And you can see this contraction keeps on happening even after 90 degrees, meaning that even we block the elbow flexion, biceps keeps on contracting throughout the range of elevation. And that is probably because of the co-contraction phenomenon, which is seen in brachial plexus palsy patients, which actually not seen in traumatic or probably paralytic patients, but it is a typical finding we see in brachial plexus patients. Now, what I found, and we discussed already, this group of patients is showing weak lower subscapularis, weak triceps, and wrist dorsiflexion, which points to, as Scott said, a C7 element. And as Dan mentioned, that when the C7 is predominantly involved compared to C5, 6, this patient's external rotation is more preserved than internal rotation, and hence they have limitation of reaching midline, or they have external rotation contracture. If it is long-standing, then it can lead to capsular contracture as well. And we all know there is a deltoid rotator cuff force couple happening at the shoulder joint, wherein subscapularis from the front and teres major and infraspinatus from the back contracts, and it keeps the glenoid, the humeral head compressed up against the glenoid, which is also known as concavity compression. If it is well centered and there is enough compression force across the shoulder joint, then only deltoid can take over, or the abductors can do the elevation. But in the presence of subscapularis weakness, this anterior stability during shoulder elevation is missing. And probably because of that, the shoulder gets anteriorly subluxed in the degrees of abduction, which is also termed as antero-superior pseudo-escape in the adult sports medicine terms. Now, this phenomenon was explained well by these papers and these authors. What is interesting, though, is how this pseudo-escape is prevented by application of elbow extension splint. To understand this, we must know that when we all know that there is only one muscle which crosses the elbow as well as the shoulder. And as Praveen rightly said, long head of biceps is a biarticular muscle. And if we study this kinesiology in details, biceps had an important role of dynamic anterior shoulder stability, especially in the absence of other muscles which are the prime stabilizer like subscapularis. When subscapularis is weak, long head of biceps plays an important role, and its axis of pull is same as the axis of supraspinatus, meaning that long head of biceps provides an important concavity compression, and it also lowers down the humeral head with the degrees of elevation. If we understand in greater details, as Stephanie pointed out and as Praveen mentioned, when the elbow is flexed, and this is the attachment or insertion of biceps, the momentum of biceps is about 1.5 centimeters. But with the elbow flexion, there is a slack in the course of biceps, which is analogous to the patellar tendon after correction of crouch deformity. So there is a slack in the course of biceps. And so even after contraction, biceps is not effective. And that is termed as active insufficiency of biceps. But the moment you extend the elbow, what happens? The biceps momentum reduces to 0. And the pressure applied on the humeral head increases by 1.6 folds. And that increased pressure due to reduced momentum leads to anterior stabilization of humerus during elevation. So I feel that there is a conglomeration of the things like the weak subscapularis does not play a role of anterior dynamic stabilizer, and biceps also cannot play the role because there is slack in its course when it is flexed because of co-contraction. But the moment it is extended by the mean of a splint, this slack is removed, the momentum is reduced, and it exerts more force at the proximal end, which probably helps into stabilizing the shoulder joint. And this role of long head of biceps as a dynamic anterior stabilizer has been very well studied and published in adult sports literature. However, when I have talked to the shoulder surgeons, they feel that the long head of biceps is a vestigial or rudimentary muscle. But contrary to that, when we have done the arthroscopic examination, The long head of biceps occupies almost 50% of the cartilaginous head surface. And in children, young children, it is not a vestigial muscle. It is an important dynamic anterior stabilizer. And this understanding has significant surgical implication with the patients in positive elbow block test. And that I would like to discuss in next part. So Johnny, I'm happy to go on. But if any question is there, I think we can discuss about it right now or later as you suggest.
I think let's go straight to the surgical, if that's okay with you. Let's go straight
I'm
to
fine.
yeah.
Okay, right. So what we have observed that the patients with positive elbow block test, their limitations are not just limited to the shoulder, but they have multi-level affections at the shoulder and as well as the distal joints. And if we list them, at shoulder, they have limited abduction, only secondary to anterior instability. They have limited internal rotation, as Praveen pointed out, with hand to belly less than 3 degrees in about 80% of patients. And they do forward trumpeting, which again is related to some extent with the posterior capsular contracture that I'll discuss. At elbow, we found that these patients have elbow extension weakness, and it has elbow flexion deformity in about 40% of patients. And some of them have normal triceps, and still they have elbow FFD, as Praveen pointed out rightly. In forearm, we saw supination deformity in about 30% of patients, and they have poor release and wrist drop in some of them, which all suggest that they have evident C7 involvement. So if we look at what interventions we did, and that is very important, for patients with anterior instability and limited elevation, we have done pectoralis major transpositioning, mainly of the clavicular head of pectoralis major, and perform teres major to infraspinatus in patients who have terminal external rotation limitation. For limited internal rotation, we have done arthroscopic posterior capsular release. For elbow extension augmentation, we have resorted to brachialis transfer to biceps or triceps, depending on the strength. For forearm, these patients required pronation osteotomy or biceps rerouting based on the fixed or flexible deformity and the strength of elbow muscles. And at wrist, some of these patients require fusion or tendon transfers. Now, I will discuss few surgeries which are not commonly done in C5-6 cohort as separately. But if we look at the percentage of patients which require this surgery, about 95% of patients required shoulder rebalancing in order to improve their elevation. About 1/3 of patients required arthroscopic posterior capsular release to improve their hand to belly function, or when they were complaining of inability to perform midline functions. About, let me see, about 40% patients required brachialis to biceps or triceps transfer, and about 19% patients required forearm positioning, and 15% patients required wrist and hand intervention. Now, when we compare this amount of intervention with the patients with negative elbow block test, we found that while 96% of patients required conventional internal rotator release and tendon transfer in order to improve external rotation in negative elbow block test, very less amount of 3% patients required arthroscopic release. Only 10% patients required, 18% patients required elbow procedures, 10% patients required forearm, and less than 5% patients required wrist or hand procedure. Meaning that the patients with positive elbow block test have a more severe multi-level affection, and they require more number of surgeries compared to the negative elbow block test patients. And we perform staged procedure. The question is why staged and why we cannot perform at one level at one time. The answer is the position of immobilization immobilization is different when we reconstruct the shoulder. We need to have elbow inflection of certain degrees, and when we reconstruct the elbow extension, we need to have elbow in extension, and thus the positions of immobilization is different, and so we need to stage these procedures. And many times elbow extension augmentation leads to improved elevation or abduction, and hence we might avoid the shoulder surgeries, and so it is wise to stage them. And we typically delay the wrist fusion operations after 10 years because we have seen higher rates of recurrence of the deformity because the carpals are chondral and it does not induce good degrees of fusion. And so we are typically delaying this wrist procedures after 10 years. And hence I term them as staged multi-level surgeries for patients with positive elbow block test. Now, I would like to describe three procedures which are not routinely done in a typical upper plexus palsy, and one of them is transposition of clavicular head of pectoralis major. Now, this concept was introduced by Dr. David Chuang in 1998 in his monogram, and I had a huge discussion with him that you do not need this surgery in all your patients because even after doing that, we have seen improvement in abduction and external rotation in C5-6 cohort. But I felt that this pectoralis major transpositioning provides some form of anterior stability. And hence we modified this technique by changing their insertion point, and which I would like to show you through a surgical video, a very brief video. So for this, there's an anterior incision and we follow the areolar plane to separate the clavicular and the sternal head. And once we separate them out anteriorly, you will see the connecting vessels between the sternal and clavicular head, and you have to preserve it. Then you separate it from the deltoid, taking care of cephalic vein. And you have to isolate the clavicular part of the pect major as like this, and carefully divide it near its insertion. And once you lift it, you will see the medial and lateral fascicles. They are single nerve fascicle with the vessels. And then you release it from its origin and you shift the whole unit laterally like this with intact fascicles. Abduct and internally rotate the arm and tie or suture this lateral end of pect major lateral to the greater tuberosity, lateral to the biceps on the greater tuberosity, as proximal and lateral as possible, so that when it contracts, it will internally rotate and to some extent produce some concavity compression of the humeral head. The medial half of pectoralis major clavicular part is sutured to the lateral part of clavicle, and so the medial end of clavicle remains bare. In this particular patient, we also did teres to infra transfer and show the plaster was applied in external rotation, but routinely when we perform this in isolation, the plaster should be in internal rotation with 90-degree abduction. So these are the steps, and the purpose is to shift the axis of pectoralis major clavicular head in a way that it will produce the action of weak subscapularis, although it is not as stiff as subscapularis course, but it helps to some extent in internally rotating and downward depressing the humeral head in elevation. So let me show you an example. This young girl with 45 degrees of abduction, and when we put an elbow extension splint, her abduction spontaneously improved to the full. We performed pec major transposition along with teres transfer. And at 1 year, you can see her abduction improved from 45 to maybe 120 degrees. And this abduction at 4 years was maintained. And we further followed at 10 years. She is a young girl now, but maintaining her elevation at shoulder. We started doing this procedure way back in 2014. And in a series of first 50 cases, we found average improvement in abduction of around 74 degrees after pec major transposition. The improvements were more when you also reconstruct teres to infra and when the triceps augmentation is done concurrently. What we also found, which is very interesting in these patients, are the before and after surgery axial scans. As you can see in the pre-surgery axial CT scan, there was subluxation of anterior translation of humeral head at attempted abduction. After the surgery, at least a year later, we find that these humeral heads are getting recentered without using elbow extension splint. So this reconfirms that by transferring this muscle, we are kind of recentering and we are addressing the anterior instability to some extent, which helps in achieving abduction in this group of patients. Arthroscopic posterior capsule release is a second operation which we do not do routinely in C5-6. And this is done in patients who could not reach midline or who required significant wrist flexion in order to reach midline and cannot perform midline functions, or those patients who have significant forward trumpeting in order to reach hand to mouth, which I feel that it is because of posterior capsular contracture. So lateral position is given and we use the anterior and posterior portals, and the 30-degree 4mm portals are used, and cool radiofrequency hook probe is used to release the posterior capsule, and it is released from 10 o'clock position to 6 o'clock position till we see the fibers of infraspinatus, and we do not go beyond to prevent injury to the axillary nerve. And intraoperatively, typically we find passive internal rotation improved to neutral. And we do certain manipulation under anesthesia for 5 minutes. And this is the end point. When we get it to neutral, we stop and we apply the shoulder spica in what we term in Indian culture as a blessing pose, where the elderly bless the children, where we keep the abduction 90 degrees. Internal rotation about 70 degrees, and forearm in mid-prone because many of them have supination deformity. In early results of arthroscopic release, we found that arm internal rotation deficit, which was 42 degrees preoperative, now reduced to 10 degrees at an average. Forward trumpeting reduced not totally but to some extent. And hand to belly function, which was 2.7 before, is now 3.5 post-operatively. Those patients who have persistently inability to perform midline function, we have performed leg dorsey to subscap transfer in a couple of patients, and results are awaited. And the final procedure, which is different, is brachialis transfer. Now, we learned from Dr. David Chuang and a work from Roger Cornwall that the denervated muscles fail to elongate, and the function shows that the brachialis is more involved in elbow flexion deformity than biceps. And Basim tend to tell this brachialis for elbow is subscapularis for shoulder. And I really admire and I agree with that point, because whenever we release brachialis, we see sudden improvement in correction of elbow flexion deformity, which was not seen earlier after biceps release. And so we have resorted after Naraka's meeting in 2019 to brachialis transfer. And we have experience of around 40 patients by far. Its strategy is to brachialis transfer to triceps if the triceps is weak, that is less than 4 MRC. And brachialis is transferred to biceps if triceps is strong. The prerequisite, although, is elbow flexion power should be 4 out of 5. And brachioradialis power should be 4 out of 5. And the other prerequisite is this extremity should be non-dominant, because for dominant extremity, losing of any elbow flexion power is associated with complaints from the family. And so I'm very careful if a patient is having dominant extremity affected. So how it works, for example, this girl who had undergone Botox as a young child and had elevation limited to around 90 degrees with an elbow block test. So Stephanie and Praveen, we have seen that whatever amount of elbow FFTs, that the moment you put a padded up, there is some improvement, but as Praveen rightly said, if the deformity is more than 60, this may not change because the biceps cannot get stretched, and so the slack is not corrected. So this was after pectoralis major transpositioning. There is some improvement in abduction, but family is concerned with the short extremity because elbow is flexed, and they are still not happy with the amount of overhead activity she cannot do. So we did triceps augmentation by transferring brachialis to biceps, and you can see the elevation has also improved. The elbow got straighter. The family is happier because the extremity length has improved, and now she can perform better overhead activities. You can see that by augmenting elbow extension, we are improving shoulder elevation. We have not done anything to shoulder. And this is because we are stretching, or we are removing the slack in the course of biceps. Earlier, when the triceps is weak, the co-contracting biceps flexes the elbow and its action gets diminished. But the moment we strengthen the triceps, even though there is co-contraction, the biceps slack is removed and it exerts pressure more proximally. And with the combination of shoulder stabilizing procedures and elbow augmentation, this gives good outcome. Let me show you another example. This 1.5-year-old girl, which I operated before 10 years, where I was not aware about C7 element concepts. And we performed MISR, minimally invasive subscap release, and tendon transfer. And that improved her abduction to 120 degrees. She could reach easily behind the occiput. Her active and passive external rotation was good, but family was unhappy because they were looking at very short extremity, and elbow flexion deformity was fairly high, 30 degrees. And again, you see when we apply the extension splint, abduction improves and the limb length becomes little less short. And this was the amount of elbow flexion deformity. And we performed brachialis to biceps transfer. Her tricep strength is good, but she had significant elbow flexion deformity. The moment we released brachialis, her elbow FFD got resolved, and we stitched it to the biceps. And now you can see the improvement in abduction, at the same time improvement in extension. And now the family is happy because her limb length looks okay, and she can do good overhead activities. And these patients, when we have transferred brachialis to biceps, they achieve hand-to-mouth movement in 6 months. And when we do brachialis to triceps, they achieve brachialis hand-to-mouth in 9 months. And they need, especially for brachialis to triceps, they need to do a little bit of elbow, the forward flexion in order to reach to mouth. That means that they had certain weakness of elbow flexor power. But patients who have non-dominant extremity, they have never complained about that, because earlier probably also they were not using that hand to feed themselves or cleaning the face or making hair. They were not using it. So family does not identify that, but we recognize that some degree of elbow flexion power has gone down. On the contrary, they are happier because their limbs are looking normal now, and they can do more active over the head activities. If I like to conclude my talk, what I feel is elbow block test is a sign of dynamic anterior glenohumeral instability. And patients with positive tests behave differently than the negative test or the ones with posterior instability, which we usually see in upper plexus cohort. Of course, there is some overlap. And conventional surgeries like further anterior release and transferring conjoint tendon to infraspinatus will further worsen the anterior instability. We all talk about external rotation gain after this surgery of releasing subscap at insertion, opening the capsule anteriorly, but we do not talk that what is happening with the abduction. What we have found that some of these patients where open anterior release is done, subscapular is completely transected, they in fact lose some degrees of abduction. And this losing abduction is because we are inducing anterior instability rather than providing more posterior stability. So we have to be very careful in releasing anterior structures. If I quote Dr. Michael Pearl, who is a great friend of mine, his series, he has found that 47% patients did not reach to midline. And when they inquired that what happened to their abduction, and then there was only 3 degrees of improvement in abduction. And when we compared that cohort with the release of subscap at origin, we found average improvement in abduction is 45 degrees. So inducing anterior instability iatrogenically is also a big challenge in gaining abduction. We must adapt novel strategies like to improve anterior glenohumeral stability. We have to address posterior glenohumeral capsular contracture, and we have to augment elbow extension. And staged multi-level surgeries in positive elbow block test have provided comparable brachial plexus outcome measure scores. We have measured it to lack of time. I could not discuss in details. But even though the positive elbow block test have multi-level affection, their plexus outcome measure scores were comparable to the negative elbow block test patients. And finally, I'll acknowledge all these people with whom I have been interacting for last 10, 12 years. But before that, let's have questions, and then I'll conclude my talk. Yeah.
Maulin, did you mean you wanted to, there's more to your presentation, or you wanted to?
No, I have only few acknowledgement slides. I think I have concluded my talk. So I'm happy to discuss now. Yeah.
Okay. So Maulin, that's a fantastic presentation. It's very well planned out. I believe I now understand what you mean by sections, because they all kind of correlate with each other. So thank you so much with this fantastic, and I think there's going to be a lot of good discussions. I don't mean to kill the momentum though, but we do have something. Tommy, did you want to share the slides regarding the fellowships, the scholarship? There's 2 slides that we have, and usually typically do this with our IMC webinars. They're not advertisements, but Tommy? Ooh. Okay, there's a lot going on there. All right, fantastic. Okay. We'll just really briefly go through. There's 2 things. We have kind of devised this Taiwan Peripheral Nerve Scholarship, where mainly you can visit Professor David Tron, who actually has, he's no longer in Chang'an anymore, but he's definitely in another hospital, but we can definitely visit 2 hospitals. You definitely, this is a full scholarship for $7,500. And we take applicants, just to come here, and then it's a brief amount of time, and you can kind of travel 3 locations within 1 year, to kind of visit the different hospitals, different centers. This is not limited to neonatal brachial plexus palsy. Obviously, it's anything related to peripheral nerve. Applicants have to be about 1 to 10 years of practice as a staff. The requirement is that you have to submit a 1-minute video to the IMC Facebook page before December 31st. We have been kind of promoting this for a while now, but unfortunately we haven't really gotten a lot of videos submitted. But there's still a lot of chance. I think this is a very nice scholarship with a lot of money to kind of allow you to kind of see around in Taiwan. And that's kind of our intent for this. So please feel welcome to reach out. Tommy, next. And then we just have a bunch of instructional courses that we did where we had a lot of live surgeries, brachial plexus, facial paralysis related. We've now kind of, they used to be in DVD. We have kind of uploaded now to like actual videos that you can download online. So if you're interested in buying these videos, just kind of scan this QR code. And there are lots of international guests in here, like Dr. Oberlin, Dr. Sumsak. Dr. Alan Joubert was also in both of the both of the courses with us. So this is an excellent opportunity to kind of join in and just to see the surgeries that are involved with live patients. Okay, all right. Tommy, could you kind of turn that off, and then we'll kind of go back to I just want to see the whole full screen. Okay. All right. Could the panelists kind of turn on their videos? And I think, Steve, you had your hand up really quick. So, Steve, go with your comments and questions. Thank you.
Yeah.
First, Maulin, congratulations. A great talk. And thank you for sharing. You have a huge patient cohort, which I think is very valuable. But also, as you noted at the end, a lot's being done to those patients to achieve overhead motion. And so I wanted to just introduce a little bit of a provocative concept that perhaps, while we know that the long head of the biceps can provide dynamic anterior stabilization. I mean, one of the reconstructions for GERD is stabilization of the long head to the anterior glenoid. And certainly putting the patient in extension places this on stretch as well. But perhaps this really is a triceps problem, because by putting them in extension, you're also relaxing the triceps. And we can't forget that the long head of the triceps also crosses the shoulder, right? It has substantial attachments to the posterior capsule, as well as the infoglenoid tubercle of the scapula. And so when you put the elbow in extension, you're also relaxing the posterior capsule. And you don't need a lot of posterior capsular contracture to have issues. The sports guys will talk about the fact that you really only need about 5 to 10% of contracture of your posterior capsule to end up having translational changes in your humeral head. So you'll have like superior displacement in abduction, external rotation, and your contact pressures increase with that. So maybe what we're seeing is that while the triceps is somewhat intact and one of the heads is working with C8, C7's not. So not only do you have that subscapularis insufficiency, but perhaps some denervation of that long head. And these kids clearly have abduction. They have C5 and they have ER. They have C5, C6 recovery. C7's the issue. And so they should have internal rotation with the upper subscap. And maybe this is just actually a secondary GERD that we're seeing, and it's a primary triceps contracture and insufficiency problem. So did you do any functional EMG of the various heads of the triceps? What happens if you just reconstruct the triceps? Because when you're doing the pec major to greater tuberosity, that's also creating an abduction moment arm, right? And so if you just were doing an internal rotation reconstruction, that would be pec minor to the lesser, like what Bertelli did for those secondary internal rotation problems.
Right. So that's a great question. And that was asked by a lot of colleagues earlier, but I'll tell you my experience. We have certain patients, and I can share those videos as well. So patients with around 50 degree of elbow flexion deformity, and I asked family that what is more concerning, your child's inability to elevate the shoulder or your elbow flexion? And I prefer to address that problem first, which will give a more successful outcome so that they will come back for the second procedure. Many of them, they were concerned with the limited elevation. And when we performed this pec major transposition with or without teres transfer, they were here and now they are here. You understand what I mean? So still they have elbow flexion deformity, still their triceps is not relaxed, but they gain the elevation. And so I thought that the triceps probably is not the culprit, although we must we would study that with surface EMG. But those patients who have persistent elbow flexion deformity, they still improved in their abduction, and I'll share those videos. However, we found in some of these patients, when after pec major transposition, their elevation is not complete. At the second stage, we do this. There are many patients where they were concerned about the length of extremity, and there we have performed triceps augmentation first. And many of them, they have shown not full abduction. So they are straight, but they are like there. They are not here. But when we combine these two procedures, their ultimate elevation is quite significant. And then they are kind of happy families. So the one point which I take it from you is that we have to do selective EMG of triceps to heads, and that will give us a clue. But the triceps lower end, it's inserted below the glenoid, and it gives some attachment to the inferior capsule. So I thought that this might be the conflict, but I found these patients who are improving like this, and so I felt that whether we should consider triceps as one of the etiologic factor or not, but we will study that definitely. Thanks for that question.
Next, I go to Scott.
Yeah, just a couple comments and questions, actually. I have some question mainly about the elbow contracture and then the brachialis transfer. In other words, do you have to resolve the elbow contracture with whatever Botox, casting, whatever, before you transfer the brachialis? That's number one. And number two, we've learned that a reinnervated muscle loses its ability to selectively fire, like Narakis used to talk mass innervation, right? So after the brachialis transfer, have they had trouble isolating their biceps from their brachialis? So two questions. One, do you have to resolve the contracture? And two, how do you deal with the potential problem that they can't separate their biceps from their brachialis in contraction?
Yeah. So that is the reason why initially they cannot reach to the mouth. Immediately after surgery, they reach here, they have full elevation, full extension, but they take certain degrees of rehabilitation in order to reach to mouth. So I agree with your finding that they cannot separate, but eventually with rehab, they can reach to hand to mouth, and that is fairly easy in most of the children who undergo brachialis to biceps transfer. When it comes to brachialis to triceps, some patients could not reach to mouth. I inquired with Dr. David that when would you transfer? And he said if the brachioradialis is functioning well, its power is 4.5, then these patients would reach to mouth. However, in few patients, we saw that even though brachioradialis power is good, they have difficulty in reaching to mouth, and they need substantial forward flexion to bring the biceps in gravity eliminated position and to reach to the mouth. But as long as that is their non-dominant extremity, it's what we found as doctors, but not the family. Or our therapist told us that it has been 6 months, but still we are not reaching to mouth. But the family is happy because of their appearance and their overhead activities. So one more point is the patients with deformities more than 30 degrees, we added anterior elbow capsulotomy after releasing brachialis. And more than 30-40 degrees elbow FFT needs anterior elbow capsulotomy besides brachialis release.
All right, fantastic. Let's move to Dan.
I mean, what can I say? Maulin, this is, I feel embarrassed actually that I have a lot of patients that would probably have benefited from their elbow, and I have overlooked that. So thank you for pointing that out. I think, what we're sort of starting to do, and more globally, and I think what you're talking about is a part of it, what Bassam is talking about. We talked about this on the Palm session last week. There's this concept of co-contraction. I think it's something that's really big. I think the concept of stability of the shoulder, as Savan pointed out, as you pointed out, as Bassam pointed out, I think that is really important. And I think that having a stable shoulder is so valuable. Obviously, a child is not going to move their shoulder if they're going to feel apprehension. It's called apprehension for a reason, right?
Yeah.
And they will not move their shoulder. I think that, therefore, we're starting to sort of coalesce around this idea that we need not just joint motion, and not just muscle power, but we also need stability of the shoulder to be able to really get the kind of motion that we want. And then if you add to that, in addition, the concept that the child is not going to move their shoulder if they can't control their elbow, that's also really important. And I think that this is a big step forward, and I really congratulate you on this. I think that I'm thinking about this very differently now. And I think that the population, my other comment is I think the population that we're looking at, that you're really looking at, is the population of 5, 6 ruptures, 7 avulsions, 8 partial injury. That's kind of where we're dancing around, right? And I think that this is why you're seeing the lack of, as Steve pointed out, the lack of long head of the triceps, which if you think about it, obviously if you lack your long head of the triceps, that's actually a benefit, I think, in abduction. Because what I've seen many times is if I've seen that triceps be really tight and I've released that triceps, the long head of the triceps, and I've been able to get more passive abduction. And so I think if you had an avulsion of C7 where you lose your long head of the triceps, I think that's why you're not seeing this. And to Steve's question, that's why you're not seeing this as a problem, because it's taken itself out. And so what becomes more relevant is the ability for you to extend the elbow. Yeah. So I think this is a fairly common patient population. 5, 6, 7 ruptures, 7 avulsion. And
the next time, next time when you go to your clinic and see a child, when you ask to elevate, they do this, and then you will see all the 6 signs in that patient. They will improve with application of extension splint. They will be losing. Their hand to belly will be compromised. They may have weak triceps. They will be doing forward trumpeting. So it's a clinical synopsis. But the first thing, the child comes into our clinic and we ask them to lift both hands and they will do this. So this is the first sign that guides us now. And even now there's so many patients that we now know that this is a C7 cohort with, as you said, 5, 6, 7 and a partial rupture of C1. What I feel is that these patients, now it's a time, of course, we need more studies, but we have to classify them based on their instability. C5, 6 patients have more posterior instability. These patients have more anterior instability. And the third cohort of panplexopathy has a global instability, where you have to induce multiple tendon transfer. In some of these patients, we have done triple tendon transfer, pectoralis major transpositioning, teres major to infra, and trapezius to deltoid. So they have the global instability, and they are more complex problems. So maybe we need more robust study, and we all can comment on how we can found, but the Naraka's classification is not of great use when we see these patients after their infancy. That's what I feel.
Well, I think you're right. I mean, the Naraka's classification was meant to be done at 2 to 3 weeks.
Yes.
So I think it sort of loses its value. And you said you were proposing a new classification, so I'm really curious as to your thoughts, because we have one coming out in Journal of Hand Surgery European very soon. I'm wondering if we align.
Yeah. So I feel that's 3 things: posterior instability, anterior instability, and global instability. That's more, it looks like pertaining to shoulder, but this cohort has multi-level affection, right at elbow, forearm, and wrist and hand also. So, but we need more patients, and we are working on that, and we'll discuss that point with you.
Good job, Maulin. Thank you.
Yeah.
I would like to get Eugene. I think Eugene, you had your hand up.
I think it's such a well thought out progression of studies, and it really makes it difficult to challenge any of your findings, because I think it just makes sense in such a progressive way. I'm at least pretty convinced that the anterior instability is the primary factor contributing to this motion. But I also think that what Dan brought up is kind of what I was thinking throughout the whole talk, this concept of apprehension, because I think that explains really well the dynamic EMG findings that you saw, how children who don't have the elbow extension splint fire their biceps right away with the deltoid. It's a subconscious way for these children to tension the biceps to try to keep their glenohumeral joint stable as they're trying to activate the deltoid. That apprehension has subconsciously trained them to co-contract those. I don't think it's like a reinnervation pattern thing. Dan, Scott, and I were recently talking about the hip and how if you do a shelf osteotomy, you don't actually get that much bony stability or extra coverage of the femoral head, but it's this proprioception that you get as the shelf covers the femoral head, and that decreases apprehension and leads to improved function. And I think that's what's happening in a lot of the procedures that you're doing to stabilize the anterior portion, whether you're draping the pec major across the anterior aspect of the joint. I know Dan's been doing pec minor to subscap transfers to try to decrease loss of midline. I think all of these things are going to not only mechanically stabilize the joint, but also provide the patient with a bit more proprioception as they move their glenohumeral joint, and it'll give them more of a sense of control as they're abducting the shoulder. And so all these points, including Steve's point that it's probably a balancing factor between posterior tightness and anterior instability. It just all comes down to balance and allowing, this decreased sense of apprehension as the patient moves. A couple of takeaways that I am going to apply as a result of your talk are, in patients for upper plexus, I'm kind of giving them a standard set of stretches, external rotation, adduction, but I think it probably doesn't hurt to add these internal rotation, posterior capsule stretches on a universal basis. So I think I'm going to do that. And I think I'm going to try to think of other ways to stabilize anteriorly, maybe try to apply this pec minor to subscap that we've been doing more universally across our patients. So really well done set of studies. Thank you so much.
Yeah, and the other thing which we should do is to have different sizes of elbow extension splint in our outdoors, because it's not only the physiotherapist, but we ourselves have to check these patients and what happens to their abduction once we put the splint on. So we have around 6 sizes of different elbow extension splints in my clinic just besides me, so that I can test it instantly. Yeah. So thank you.
Right. Thank you so much, Eugene. Next we have Praveen. Praveen, do you have your video on?
I think my connection is little slow, so I will just speak maybe. Yeah.
Perfect. Yeah. Perfect.
Yeah.
Thank you.
So actually, we have discussed this, Maulin and myself, and the more when I feel that I am understanding it, that is the point I again get a kick. So one of the things what we observed in our cases which we have operated, so it is a dynamic instability. We saw that. One component which I think Maulin was pointing out, and I don't know whether it came out clearly, is that patients have a lot of co-contraction between the deltoid and the biceps. And also they have a co-contraction between the deltoid and the adductors. So now what's happening is the deltoid is contracting with biceps and adductors. So when a child is trying to do shoulder abduction, the adductors contract, they are blocking the abduction, and the elbow flexes, which makes the biceps inefficient as anterior stabilizer. So we observed that whenever these patients have more co-contraction of the adductors, just releasing of the adductors improved their shoulder abduction and reduced this elbow flexion contracture. So the mechanics which we thought in our mind was, there was an abduction, adductant contraction, and once you have released the adductors, the abductor is contracting less violently, And because of this less violent contraction, the biceps also is contracting less violently and it starts acting like an anterior stabilizer. So there is a big group of patients where just release of the adductors at the shoulder improved the shoulder abduction and decreased this elbow block test effect. But when I thought, okay, we invented a new thing and studied all of them, not all the patients showed. So then we started adding triceps to them. So in one of the meetings I had presented earlier, the trapezius to triceps transfer. For some patients, that also gave it amazing results. But the patients who have a lot of anterior instability, this trapezius, which tend to be also an external rotator when it is going to triceps, in some patients, it increased the deficit of internal rotation. So then again, that was a small problem issue with that. So presently, what I think, what worked good to restore this balance is, if we observe that these patients have good amount of abductor-adductor co-contraction, we release the adductor, we release the teres major completely, we divide the latissimus dorsi completely, and transfer the latissimus dorsi to subscapularis anteriorly. That kind of reduces that abnormal co-contraction, overactivity of the deltoid, and also stabilizes anteriorly. So this is presently what we are doing, thinking these two principles. The results are okay. It is not really amazing, which I feel like, okay, we have invented a new thing. So I think there is still some link which is missing in between. Yeah. And regarding the brachialis to triceps transfer.
So Praveen, let me answer this question first, and then we'll talk about. So I have done a few patients lower trapezius to triceps transfer, but let me tell you that it has never given against gravity elevation. It's always give a good gravity eliminated. So lower trapezius to triceps transfer is not a very good. It is not strong enough to induce elbow extension when child lifts the arm. It falls, and then the purpose of that surgery is not served, because against gravity, if it is not remaining extended, then we cannot remove that biceps slack. And so I have stopped doing lower trapezius to triceps transfer. That's one. We have also performed a few lat dorsi to subscap transfer. And this is after a huge discussion with Basim Al-Hassan. And they have been doing this for traumatic subscap tear. But remember that lat dorsi is also supplied by C7. And this lat dorsi is not very strong. So all those patients where I performed lat to subscap transfer in this C7 cohort, they have marginally improved in internal rotation and not to the substantial improvement as we see in external rotation transfers. So although I performed in few patients, but they were not very happy. They did not achieve what I promised. And so I have abandoned doing lat dorsi to subscap transfer, because probably that transferring muscle is also not very strong. Yeah.
Yeah, Maulin, I was talking about upper trapezius to triceps.
Yeah,
the upper trapezius could actually improve in overhead abduction.
Yeah.
But
so
that
you have shown
the lower
a patient
trapezius
that
surely does not.
Yeah. So I'm trying to do that procedure because you have shown a result in one of the meeting at POSICON, an upper trapezius to triceps transfer. Have you achieved against gravity extension in those patients?
Yeah, again, as I was telling, when I feel like everything is settling, then again problem comes. Maybe
So
half of them.
rotation gets affected more. Yeah.
Half of them could do anti-gravity overhead abduction, only half.
Okay.
But 1/3 of them developed the external rotation contracture, and it was quite scary because it looks like it is not reaching to the center of the body. So, but I think we would now a little bit change the technique. I am trying to go through the anterior deltoid, like take the fascia lata, go through the anterior deltoid to the triceps. So maybe that modification
Right. So that can be tried. But I'll tell you, I have done 75 pectoralis major transposition. And
yeah.
And then I added teres major to infraspinatus where the patient is not reaching behind the occiput. And these patients typically they show marginal improvement for first 6 months. And between 6 and 12 months, they show substantial improvement. And I have done pre-operative and post-operative surface EMG when pectoralis major and deltoid were not co-contracting before the surgery. After 1 year, they start co-contracting. So here, pec major now probably works as a anterior supraspinatus and helping in elevation. So I think I do not find any other option. So I keep on doing these procedures. And as I've been talking about this elbow block test and extended palsy, a lot of patients are coming. So people, they treat C5-6, but then it comes to this, they send it to me. And then that's why a lot of patients I keep on operating. And I'm going to try your upper trapezius in one of our patients.
What do you feel about only releasing the adductor and breaking that co-contraction cycle and improving the balance indirectly?
See, the adductors you are releasing is lat dorsi. Now, lat dorsi is again
teres
C7
major and lat D.
And teres major and lat dorsi. So I'm coming to that. So lat dorsi is C7. So we are weakening already weak muscle. That's one. Teres major, if you are releasing and if the child is having leg of terminal external rotation, then you better utilize to transfer to infraspinatus at a bit inferior level, which can serve both the purpose. You are releasing the so-called co-contraction. See, when we did surface EMG, we could not, the muscles are so crowded, we could not elicit a very clear co-contraction because a lot of muscles were firing. So what we found very reliable co-contraction between biceps and deltoid, but we did not find good, what you say, there are a lot of crowding and a lot of firing. So we could not conclude that there is real co-contraction between adductors and abductors. There is no co-contraction between pec major and deltoid. That's what I saw. And I discussed with Dr. Chuan that although you say that you transfer this pec major because there is co-contraction, but when we put the surface EMG, we did not find them. So, yeah. So I have not tried isolated adductor release, Praveen.
Yeah, I think because somehow the pec major translocation, I feel it is a little bit bigger scar. So I always try to release the adductors first. In case the improvement does not happen, then I go for restoring the anterior instability and improving the triceps.
Yeah. So before doing that, I would like to kind of go again to this IIT and see the surface EMG of adductors and abductors. We did not find much co-contraction earlier, but we may restudy that.
Yeah, please check. I think teres major is the one which I always see that it is very bulky. So because it is, I think, continuously co-contracting with the shoulder abductor. So maybe that is the reason why it is happening like this. Yeah. Thanks.
Thank you.
It was really interesting. It is very good. I think we have been discussing this for so long. Yeah. Having all the experts together makes it very interesting.
That's right.
Thank you, Johnny, for arranging this. Thank you so much. Yeah, thank you so much, Praveen. No, it was quite intense, but really, there's a lot of tips to pick up. Thank you. Next, I'd like to invite Stephanie.
Thank you again for the very interesting talk. A lot of good learning points and definitely things that I will be keeping in mind going forward.
So not losing much, no?
I have quite a few questions, but I'll try to limit it to a couple for the sake of time. One is just a quick question for the dynamic CT. You do that with the elbow splint on or without it to get the best assessment of the anterior instability?
Yeah, so this was done in 3 phases. The first, we asked the patient, we did at the rest, So there is no abduction. The arm is adducted, and we looked at the glenohumeral articulation. The second thing is amount of abduction on the affected side, possible abduction. And then we asked the child to do the same degree of abduction on the contralateral side. And we did the CT scan. And the third was we placed the extension splint and amount of abduction, whatever child can do. And then we repeated that scan. So we did it in 3 stages, and we did the measurement.
And did you see resolution of the anterior displacement with the splint in place?
Yes.
Okay.
So that we see constantly in all our patients. Now, some of them, like we want to see what happens when the child is upright, because we did not have an upright MR so far in our center, in our city. But now we have one. So I would like to test them in what happens with the effect of gravity, the supero-inferior stability. But so far, you will see, if you repeat in your patient, you will see a definite anterior translation that get resolved. And even we have tested it about 1 year post-surgery. And even then, the child doesn't have this splint, and the humeral head remains centered. And that's why I feel that the anterior instability is a real culprit. By doing some releases, we are not addressing that problem. But I invite you guys to study this thing in your patients also, and you will see that there is anterior translation happening when child does possible abduction, which improves spontaneously. There is recentering of the humeral head with the application of elbow extension splint.
Thank you. My next question was, I've seen a couple kids that I think kind of fit the clinical picture that you're have presented, that when they were infants or young toddlers had some better numbers for shoulder abduction and elbow extension that kind of declined over time. Is that something that you've found in this cohort of patients as well?
Yeah, so I don't know in this cohort, but we have some patients. I saw how Dr. Howard Clark was in the group, Tommy. I'm so pleased to see Dr. Clark here. Did you notice he was here?
Yeah, Dr. Clark has a question for you as a comment, but I will read it out for him because he's unable to have video. But well, I'll wait till the panelists finish.
Yeah. So we have been measuring the HSC-AMS, the Hospital Sick Children Active Movement Scale. And you're right that we saw some patients were scoring 7, but as the child improves in the elbow flexion strength, that 7 goes to 6 or sometimes 5. And then we realize that this scoring is the score of the range of motion and not the strength. And so when the antagonist strength improves, and that antagonist, if it is co-contracting, then the AMS would go down. So you're right that we have seen this phenomenon, the triceps strength or triceps range, in fact, because we cannot see in young toddlers exact MRC grading, but they lose the excursion and range. And it's because their antagonists are now more stronger.
Okay. And my last question for you right now would be, the case examples that you showed, most of the kids had what appears to be roughly 70 to 90 degrees of abduction or so. Have you done these procedures on any kids that have worse abduction initially? Like if they only get, say, 40 or 50 degrees of abduction, do you see improvement in those kids as well? Or do you need to be kind of closer to that 90-ish range to see these improvements?
Yeah. So the thing is, if the deltoid is recruited, then your abduction will improve. Meaning that we know that first 30 degrees is happening with supraspinatus, and then from 30 to 90 it's from deltoid. And that you can see through surface EMG also. So if deltoid is recruited, then elevation is bound to happen if we provide the stability. So the lowest abduction pre-op was 45 degrees. Okay? And in those patients, we can see that there is no deltoid atrophy or there is no posterior sulcus sign. So you see the good girth of deltoid, And when you put the splint, they will go beyond 90. So there, we feel that by improving the stability, as deltoid is recruited, this child will improve in elevation. But if you see a global atrophy of deltoid compared to the other side, there is sometimes they have sulcus signs. So there is inadequate recruitment, and there the abduction may not improve, even though you provide triple transfer to provide global stability. So the first prerequisite is deltoid should be recruited.
Okay, thank you. Appreciate your insights.
Thank you.
Thank you, Stephanie. I think, Dan, you had your hand up for a while. Did you want to comment?
Sorry, I must not have put my hand down.
No worries.
I don't really have it. I don't really have any other comment other than to say, like, I think we are a long way from basically the concept that everybody needs an anterior release and a tendon transfer. So kudos to really all of us for moving this forward. That's all. Thank you.
Thank you, Dan. Thanks. Michael, Mike, did you have any comments to add for this session for the treatment and the biomechanics?
I just second everything that's kind of been said. I really feel like you're hinging on something with the stability concept that we're going to follow into the future and really see where this plays out, because that's the most important thing that I think we're looking at. It's getting that to not only what Dan was saying, it's not just anterior instability or posterior instability. It's kind of solving the question of how do we balance those two and where that brings us into the future. And I think the studies that you're talking about and what you're doing is really key, because we see these observations in patients and then we ask these questions, but just like you're doing, we have to study them and actually see what's going to come of this and then what surgeries benefit them. Because this subgroup of patients that we're talking about, the 7-8 patients with 5-6 recovery, are very different from the patients that have the 5-6 injuries plus 7-8 that were doing these anterior releases and lat teres or lower trap transfers for. So we also may need to study in the future what the secondary surgeries and what the concepts of these things become after initial surgery at a young age for those patients too, because they sometimes fall into this category as well, where we operated on them to do anterior releases, transfers to do external rotation and abduction, and sometimes they look similar to this, where they get some of it, but then they still have that elbow flexion contracture or an abduction contracture. And then we see secondary problems related to that, related to GERD, where they lose the internal rotation. So I think the native patient population that hasn't been operated on should also be looked at against the population where we potentially did too much or unbalanced the shoulder in a way too, and see what those compare to as well.
Yeah, so those iatrogenic external rotation contractures and limited abduction secondary to that is really challenging, because these patients which I discussed have some form of subscap. It is weak, but there is some form of subscap there. But when you do a complete anterior release with anterior capsulotomy, and you are happy to see the humeral head coming out in front, where I get scared, because when you are seeing a humeral head in front, I'm seeing this phenomenon. So, and when I see this phenomenon where my colleagues have operated anterior soft tissue release and tendon transfer, and then and they say, do you do one surgery and fix it? And I said, no, we are heading for 3-4 surgeries over your childhood, not one surgery. You will need multiple operations at shoulder, at elbow, and maybe at forearm as well. So now when such patients come, I make a table for them. What is your problem at shoulder? What is the problem at elbow? What is forearm and this? And then I write down what procedures we will do, 1, 2, 3, 4, and then what stages we'll do. Many a times you can do forearm pronation and shoulder arthroscopic release and tendon transfer in one go. But mainly the elbow extension procedure, they have to be done at the second session. And there we take, I ask family that what you want first. Do you want correction of elbow first or the shoulder first? And accordingly, I'll go, because I know that they need multiple surgeries. And if I give a satisfactory outcome in first surgery, then only they'll come for the next. If I do something heroic and they are not aware of that limitation the child has, then they might not come for the second operation, you know?
Right.
So, yeah.
The other one thing that I wanted to point out, I think the CT scans that you showed did not have glenohumeral joint dysplasia.
Yes, that's very important.
The other thing that we potentially need to look at is, where does glenohumeral joint dysplasia fit into this stability problem? Because when we're seeing these pseudoglenoids or asymmetric glenoids, where does that then fit into the category of anterior and posterior instability? Because you don't have a normal concentric teacup glenoid. You have this kind of unstabilized eccentric glenoid. So it's going to be interesting to see where those fit in as well. And I think your MRI and CT study will kind of elucidate that a little bit too. Because a lot of times I see that if you reduce the shoulder away from that pseudoglenoid, you actually get better motion and more biomechanical integrity. So you have to see what that's going to fit into this too. And that's a question that's even more complicated, but I think is something that we're going to address as well.
So Mike, I have stopped doing MRIs for these patients because we have done tons of MRI and we found that they are congruent glenohumeral joints. There is no retroversion, there is no subluxation. So glenohumeral joint is congruent. There is no static anterior instability, you understand? So now I know that because when you have too much of external rotation, you cannot have retroversion of glenoid. You understand what I mean? Because for having a retroversion and subluxation, you need to have internal rotation contracture. And when you have external rotation contracture, glenohumeral joint is always going to be normal. And it is not anteriorly dislocating at rest. It dislocates or subluxates when you attempt abduction. So it's a dynamic phenomenon. It's not a static dislocation, as we see in posterior instability patients where they are lying behind. So we have stopped doing MRIs for this cohort of patients because they are anyway going to be well located.
Thank you so much, Mike. That's great comments. Stephen, you had your hand up. Stephen, you're muted.
Thanks. I just wanted to, just provide one final comment of appreciating how complicated these problems are in the children that are presenting late without prior, microneural surgical care. There's that huge paradigm shift that happened in our field where, we're operating on these babies too much. We're doing too much nerve surgery. They are recovering. They're getting back neurological recovery. But the truth is that while there might be some neurological recovery that's happening, there's so much deformity and there's so much lack of functional recovery that's happening by not providing early nerve care to these babies that, sitting in a session like this just really reinforces the need to capture those babies like you're doing now before the age of 12 months and intervening where you can make a global difference instead of all these band-aids we're slapping onto these children to get them to do things. It just really reinforces, I think, a little bit of perhaps a coming rubber band effect that we might see in our field. And hopefully we can find a middle ground.
So Steve, I heard from my nerve surgery colleagues that if you operate upon them earlier, then you can prevent co-contractions, right? But I'll tell you that about 20% of these patients, of 156 patients, have undergone nerve surgeries in an infancy. So when you have limited improvement in C7 or you have avulsed C7, then also you will see the similar phenomenon. So it's not that you operate, you do the nerve surgery and you will not see this phenomenon. That depends on the severity of injury you have. You're right that if we operate early, and most importantly, as you said, it's triceps. I always say that you reconstruct triceps. Because if triceps is weak, then these children will need multi-level surgeries. But if triceps is strong, then this transposition also functions very well. So although we take biceps in consideration for the nerve surgery indication, but to me, the triceps strength is very important. And that we should
I love that you highlighted that. I love that you highlighted that.
Yeah, that's right.
All right. Sorry, I had to go to the restroom for a sec. All right. I think Dr. Clark had a comment. I just wanted to say it now. What Maulin describes as a passive internal rotation deficit is better described as an external rotation contracture. In these patients, if you passively move the scapula into the anatomical position, you will find the limb rest in the external rotation. The paradox is that they have limited external rotation in the presence of an external rotation contracture.
So I purposefully did not mention external rotation contracture because it's a combination of both the capsular contracture and the muscle contracture. So many of these patients, when we do arthroscopic release, and still they do not reach midline. And those patients have tight muscles, and we have fear that if we release them, the patient will lose certain degrees of external rotation, right? So we do capsular release, and then we reinforce rehab to gain internal rotation. We wait for a year, and if still the reaching midline is a problem, then we would consider some form of tendon transfer. Lat dorsi to subscap is one, but that has not given great outcome in my patients at least. And the reason is it's not like subscap traumatic tear, it's a palsy. So C7 is already there. So lat dorsi is not as strong as we see in sports injuries patients. Yeah, so I agree with what Dr. Clark said.
All right. I think we've kind of reached the 2-hour time point. Maulin, did you want to show something at the end of your presentation?
Yeah, I'll resume that, and I acknowledge. So I acknowledge my communication with this colleagues, these stalwarts of our field, Dr. Waters, Dr. David Chon, Basim. Basim is a great help because he has seen the sports injury world as well. So I respect his comments. Dr. Jilbe is always encouraging. Andy, Roger, and Sevan, who has encouraged me to present and work on my studies. And Praveen, he's a great colleague. There are very few people in India to whom I can talk, and Praveen is one of them. So thanks, Praveen, for being there. And finally, Johnny, that short meeting of ours at Brachial Con, and you gave me this platform. So I'm so much thankful to you and your team. And this is the best platform I think I could presented my research work to this panel of eminent brachial plexus surgeons. And I'm open for further collaboration and your ideas. I'm giving my email ID. So if you think we should discuss further, I'll be very happy. This is my WhatsApp number. And behind me, these two gentlemen, Dr. Nishchal and Tejas, they have always questioned my findings, and they are instrumental and they are pillars of my presentation. So I thank them as well. So thank you very much, everyone, for your comments. And I have noted those areas where you have commented, I'll work on. And if I get some answer, I'll come back to you. Thank you very much. Have a great day.
All right. Thank you, Maulin. I think just kind of unshare if you can.
Can I stop sharing? Yeah.
Yeah. Just stop sharing. Yeah. Yeah. All right. Maulin, there wouldn't be that much discussion if it wasn't for the content of the presentation. So just congratulations. I think we had a chat about where to publish this. I think you have a lot of reviewers on here as well. So those are great, insightful comments for you. So I hope you can get this published. You have a lot of data that's worthy of comment. So I think that's so thank you so much, Maulin, and look forward to the next session together. And so thank you so much, all of you, for getting together. And thank you. And Tommy, did you have any final comments?
Yeah, thank you, Maulin. I think this is very, very challenging, the brachial process, and thank you for explaining everything and very good case demonstration. We really appreciate it, and thank you for so many kind words for our great teacher, Professor David Chuang. And thank you all the teachers with the comments. Today we have Dr. Besides the panelists, we also have Dr. Gilbert and also the Dr. Howard Clark from C-Kids for the comments. So really appreciate all the teachers' feedback. And thank you, Johnny, for arranging everything. And I believe by the cooperation with the ASPN, we'll have more and more great lectures in the future. So thank you, everyone, for joining. I hope those techniques can help the patient from different parts of the world. So thank you so much, and we'll see you tomorrow. Thank you. Bye-bye.
Thank you, guys. Thank you.
Thank you.
Have a good day. Bye-bye.